So this patient has varicose veins, which cause aching, burning, itching, swelling, restless leg symptoms, pain. So varicose veins there are several risk factors, but the biggest risk factor is who your grandmother was. So they're really more genetic than anything. If you stand for long periods of time like nurses, teachers, factory workers do, that increases your risk. Pregnancy, hormone changes also increases your risk. So this patient has what we call chronic venous hypertension or chronic venous insufficiency. And that is caused by a defect in his vein valves. So in the venous system, there are two major systems that carry the blood back from the feet and the lower legs up to the heart. One is the deep system, which carries 90% of the blood from your foot to your heart, and we never enter the deep system. That's where you have the scary blood clots. The other system is called the superficial system, and it carries the remaining 10% of the blood back from your feet to your heart. And the superficial system dumps into the deep system. The deep system is a high-pressured system, and when the superficial system dumps into the deep system, there are these one-way valves that close to keep the blood down in the deep system. If the valves are diseased and they don't shut properly, then the blood from the deep system pulls back down in the superficial system. You're good. And the veins on the surface of your leg have to dilate to take care of that pressure. And that's where the varicose veins come from. Part of the process is that the vessel wall becomes diseased, and inflammatory cells that should stay in the blood leak out of the vessel wall and cause the burning and the itching and the heaviness. And you can also get some skin discoloration, some dermatitis, and eventually some folks even end up getting venous ulcers. This patient has what we call venous reflux, or non-functioning valves of his great saphenous vein, which starts on the inside of his ankle and goes all the way up the inside of his leg and dumps into the deep system up at the groin. And we are going to laser this much of that vein shut. So endovenous laser ablation or therapy has been around for what? Since 2000. So it's a fairly new procedure, and it was invented by an interventional radiologist while he was a resident, Dr. Mim. He's a very bright guy. So we're going to access the great saphenous above the knee. Some people will go below the knee. The saphenous nerves runs real close with the saphenous vein in the lower part of the leg, and you can get some neuropathy if you're not careful. So we usually stop the laser above the knee. The great saphenous vein runs in a sheath, a fascial sheath, and some people call it the Cleopatra eye because it looks like an eye. Okay, so she's going to trace the great saphenous up to the groin, and it's that black dot there. So we're going to numb the skin up before we stick him. Okay. So we've got the needle in the vein. Now we're going to thread the guide wire through the needle into the vein, and that's that bright line you see going into the vein. See, that was much better, huh? That's all we want to hear. So now we're going to put an introducer over the guide wire into the vein. And you may feel some pressure now with this introducer, probably not much. And now we're going to thread the laser through the introducer up to the groin. Can you show them that tributary? See it? This is a tributary vein coming off the great saphenous. It's probably refluxing or not healthy. Okay, is that good? Yeah, so here's the deep system right here. The great saphenous dumps into the femoral vein. Okay, so we usually thread the laser up to about 2 centimeters distal to the sapheno-femoral junction, we call that. Okay, Matt, now comes the sticking.
Good.
Sorry. I'm just apologizing. Stick. Stick. So we're numbing the skin up right now. Nobody likes this part. Okay, so now we're going to numb the vein up. And we use a dilute solution of lidocaine with sodium bicarb. Okay, what this does is it numbs the vein and creates a heat sink so it protects the tissue around the vein, and it also makes the vein collapse because it's important for the vein to be collapsed. The laser targets the water in the vein wall cells so that it destroys them. So a 1420 wavelength that targets the water in the cells. All right?
Okay.
See the little bright moon-looking spot in the middle is the laser. And this machine that's delivering the lidocaine is called a Klein pump. And Dr. Klein invented the machine to do liposuction. It's called tumescent anesthesia. When we first started doing these, we used to do this by hand, pumping back and forth. So this is it's a great invention. And Stacy's following the laser down to make sure we've got enough numbing medicine around it. Usually want about 10 cc's around it. Okay. So we are gonna tip his head back to drain the vein. So it's all about compressing the vein down. So when the laser starts to move, I'm going to fire it, and you'll see the bubbles coming out as the laser heats up the water in the cell walls. And the laser pulls back 1 millimeters a second. So the great saphenous vein actually continues on down to the inside of the ankle, and we will close the rest of it down with foam sclerotherapy. So you have to close the whole vein down, or it'll cause, you just don't get a good treatment. The rest of it will reflux, or it'll cause more problems. So you try to close it all down. Okay, so what we're going to do now is close the remaining portion of this great saphenous vein from here down, and we're using sclerotherapy. It's a Sclera is the company that makes it. It's really polydocanol. It's a detergent, and it actually targets the vein wall. It denatures the proteins in the cells of the vein wall, so the vein wall collapses, and eventually the body reabsorbs these veins that are destroyed. They won't be seen in about 6 months. So what we do with the sclerotherapy is we put some air in it so that it will stick to the vein wall longer and cause more damage. And this is called foam sclerotherapy. So this is the vein, the dart, yeah, you point. So we're gonna watch the needle go into the vein. Sorry. We're just going to ignore the patient. And the bright snow-like stuff is the foam. So you can see the foam in all the little white vessels that she's running up and down. You can see how the foam has traveled into veins in other parts of the leg, into tributary veins. So once again, we're going to direct the needle into the vein. And then you will see the foam. It's the bright snow-looking stuff. Sometimes you can see it go to the surface, but we're not going to be that lucky today. That's okay. It's running good. I got some. Huh? Feel? So here's a tributary vein off the great saphenous vein. So it's if they're bigger than 3 millimeters, they're diseased, and that one's, what would you say, 5 or 6 or? Oh, I'm sorry. So that one's about 6 centimeters. If they're bigger than 3 millimeters, excuse me. If they're bigger than 3 millimeters, they're usually diseased. And this one's about 6. So these veins, if you don't get them, will eventually come to the surface and be varicose veins, and you don't have a very happy patient when that happens. So we try to close all these veins down. Right? Okay, that's it. You made it. Yeah, you're done. So what we've done is we've closed down the great saphenous vein from the groin to the ankle using the laser and the foam sclerotherapy, and you know, preparation time is the biggest part of it. It takes 20 minutes to do the actual procedure. It's done under local anesthesia. Some of our patients take an anxiolytic, others don't, and they're up walking after they're wrapped, and we expect them to walk 3 times a day, at least 20 minutes, 3 times a day. And they have to wear their compression hose for 3 weeks. That's the part they don't like. That's a wrap. And that's what it is.